Hello and welcome to this overview of Pompe disease, also known as glycogen storage disease type 2 or acid maltase deficiency. This lysosomal storage disorder, first described by Dutch pathologist Johannes Pompe in 1932, affects about 1 in 18,711 to 1 in 40,000 people worldwide. This is more common than once thought. It demonstrates how a single enzyme deficiency leads to multi-system failure, progressive muscle weakness, and potential death if untreated. The disease's spectrum ranges from fatal infantile cardiomyopathy to gradual adult onset weakness, all from mutations in one gene. Enzyme replacement therapy has improved outcomes, but challenges persist in managing muscle damage and cellular dysfunction beyond glycogen buildup. Next, we'll explore its epidemiology. The epidemiology of Pompe disease has been transformed by newborn screening, revealing a higher prevalence than once thought. Global data from over 11 million newborns across 8 countries from 2010 to 2022 show a birth prevalence of 1 in 18,711, or 5.3 cases per 100,000 births, surpassing older estimates of 1 in 40,000. Prevalence varies by ethnicity, with higher rates in East Asian, non-Finnish, European, Ashkenazi, Jewish, and African American groups. Infantile onset Pompe, the severest form, affects 1 in 126,118 births, about 15% of cases. Late onset Pompe varies widely, with diagnoses from childhood to age 80, averaging 38 years. Gender distribution is equal. These findings shape healthcare and screening strategies. Let's dive deeper into what causes this complex disorder. Pompe disease stems from biallelic mutations in the GAA gene on chromosome 17q25.2 through q25.3, which encodes acid alpha glucosidase, a lysosomal enzyme that hydrolyzes alpha 1,4 and alpha 1,6 glucosidic bonds in glycogen, providing the only route for its lysosomal breakdown. Spanning 20 exons, the gene harbors over 560 mutations, including 51% missense, 14.9% small deletions, and 12.7% splicing variants, and 8.8 nonsense types, creating varied genotype-phenotype relationships. As an autosomal recessive disorder, it requires mutations on both alleles for expression. Residual enzyme activity dictates severity. Total absence triggers classic infantile onset with rapid cardiomyopathy and death by year 1 untreated, while 1 through 30% activity yields late onset forms with progressive features. The prevalent C-13T2G splice mutation found in 40 to 70% of Caucasian late onset Pompe cases allows for minimal normal messenger RNA, slowing progression. Now knowing the genetic insights of the disease, let's classify the forms this disorder takes. Pompe disease is classified by onset age and severity, reflecting GAA enzyme deficiency levels. Classical infantile onset, the severest, emerges within 3 months, showing profound hypotonia, massive cardiomegaly, hypertrophic cardiomyopathy, and respiratory failure, with less than 1% enzyme activity leading to death within a year if untreated. Non-classical infantile onset appears later in the first year with muscle weakness but milder cardiac issues, allowing survival into early childhood. Late onset Pompe, from childhood to adulthood, features preserved heart function and slowly progressive limb girdle and respiratory muscle weakness, with 1 to 30% enzyme activity. This spectrum shows overlapping features, blurring strict categories. Let's now explore its clinical manifestations. Pompe disease symptoms stem from glycogen buildup in cardiac and skeletal muscles, varying by onset. Infantile onset patients show severe hypotonia, appearing as floppy babies, with poor feeding, failure to thrive, macroglossia, hepatomegaly, and massive hypertrophic cardiomyopathy. They rest in a frog-leg position and face frequent respiratory infections. Late onset patients develop progressive proximal muscle weakness, affecting pelvic and shoulder girdles, with waddling gait, scapular winging, and early respiratory insufficiency like exertional dyspnea. Symptoms include fatigue, chronic pain, and dysphagia, often leading to 5 to 10 year diagnostic delays. Let's unravel the biochemistry behind these manifestations. Normally, acid alpha glucosidase, a lysosomal enzyme, degrades glycogen into glucose by hydrolyzing alpha 1,4 and alpha 1,6 glycosidic bonds, maintaining cellular homeostasis. This 76 to 70 kilodaltons enzyme forms from a 110 kilodalton precursor via mannose 6 phosphate receptor trafficking and lysosomal cleavage. In Pompe disease, GAA deficiency causes intralysosomal glycogen buildup, enlarging lysosomes and disrupting macroautophagy by impairing autophagosome lysosome fusion. This triggers lipofuscin accumulation, oxidative stress, mitochondrial dysfunction, and altered mTORC1 signaling. Remarkably, autophagic debris creates a vicious cycle, amplifying muscle damage beyond glycogen storage. Elevated glucose tetrasaccharide and creatine kinase mark cellular damage. Let's examine the genetic roots next. Pompe disease pathology extends beyond glycogen-filled lysosomes, showing vacuolar myopathy with enlarged glycogen-packed lysosomes on muscle biopsy. Late-onset cases feature massive autophagic buildup with autophagosomes and lipofuscin inclusion signaling cellular stress. Genetically, GAA gene mutations, especially the C-32-13T2G splice variant in Caucasian late-onset patients, reduce normal transcript delaying symptoms. Pathology progresses from glycogen accumulation and myofibrillar fragmentation to lysosomal rupture and contractile element loss. Autophagic dysfunction impairs enzyme replacement therapy delivery. Let's explore how these changes shape laboratory findings. Pompe disease diagnoses combines enzymatic, molecular, and biomarker analyses for confirmation and therapy monitoring. The key test measures acid alpha glucosidase activity in dried blood spots, showing less than 30% normal in patients, but pseudodeficiency alleles can mimic low activity without disease. Genetic testing confirms GAA mutations. Elevated glucose tetrasaccharide serves as a sensitive glycogen storage biomarker correlating with severity. Creatine kinase and transaminases are often high, reflecting muscle and liver damage. Muscle biopsy reveals autophagic pathology. Let's now distinguish Pompe from mimicking disorders. Pompe disease mimics various neuromuscular and cardiac disorders. Infantile onset resembles spinal muscular atrophy type 1 with hypotonia but no cardiomyopathy, and congenital muscular dystrophies, lacking respiratory involvement. Late onset mimics limb-girdle muscular dystrophies and Becker muscular dystrophy with proximal weakness, but Pompe's early respiratory failure is distinctive. Other glycogen storage diseases like McArdle's show exercise intolerance, not fixed weakness. Let's explore how Pompe is managed. Enzyme replacement therapy is Pompe's cornerstone using algoglucosidase alpha, avoglucosidase alpha with enhanced mannose-6 phosphate targeting, or cipaglucosidase alpha with miglusat for late-onset cases. Bi-weekly infusions at 20 to 40 milligrams per kilogram restore GAA activity, but variable response and antibody formation pose challenges. Supportive care includes respiratory support, physical therapy, and nutritional optimization. This would include getting a nutritional coach to help you with your diet. Emerging gene therapies show promises. Early treatment maximizes outcomes before irreversible damage. Now let's examine potential complications. Pompe disease complications impair quality of life despite treatment. Progressive diaphragmatic weakness causes respiratory insufficiency, sleep disordered breathing, and recurrent pneumonia, often requiring ventilation. Infantile patients face heart failure and arrhythmias improved by ERT. Late onset patients develop wheelchair dependence, scoliosis, and dysphagia. ERT infusion reactions and antibodies hinder treatment efficiency. How do these affect long-term outcomes? Enzyme replacement therapy revolutionizes Pompe disease prognosis, though outcomes may vary for every patient. Untreated infantile onset patients face death within a year from cardiorespiratory failure. Early ERT reduces mortality by 95%, extending survival into adolescence, but muscle weakness persists. Late onset patients show heterogeneous survival, with 95% 5-year survival without respiratory support. Early treatment before muscle damage is critical and should be treated immediately. What therapies could further improve the outcomes for this disease? The research landscape for Pompe disease is rapidly evolving with innovative therapeutic approaches in clinical development, shifting from single treatments to multi-targeted strategies. Gene therapy leads the way, including liver-directed AAV2/ALSP HGAA muscle targeting AT845 in the Fortis trial, and AAV9-mediated GC301. GC301 shows motor and cardiac gains in infantile patients. Substrate reduction therapy like MZE 001 targets glycogen buildup, complementing ERT. Advanced ERT with sipaglucosidase alpha and miglustat enhances stability. CRISPR AI, proteomics, and pharmacogenomics drive precision medicine. Future trials explore combination therapies, neuroprotection, and stem cell repair. Thank you for viewing this video.